Hello, I'm Miss Trosclair, and this video is going to contain information about the features of a simulated patient. I'm going to go in a head-to-toe fashion, just like you would do if you were doing a physical exam. Let's start head to toe, even above the head. The patient, behind each of the patient's bedsides, is a head wall unit. That is where the oxygen supply, negative pressure, or suction source is provided for us to use when necessary. So our simulated patients can receive oxygen. They can receive them by various delivery methods, nasal cannula, face mask, and more advanced airways as well. They can also, as far as the suction device, have a nasogastric tube in them inserted through the nose and of course goes to the stomach, and it can be used to decompress the stomach or to remove the contents of the stomach. So our simulated patients have the ability to have those two adjunct equipment and treatments. All right, so looking at the simulator, you're going to find that his skin is intact right now, but I will tell you that all of the simulators can develop pressure ulcers. You're going to discuss a lot about skin integrity. So what I will say to you is, because in the other video I said play it real, remember to prevent pressure ulcer formation. They can be turned, they can be propped up with pillows. They can't move independently. They cannot move. None of them can move, except you will see that they have chest excursion and eye blink response. But that's the only movement they have. So you as the nurse would have to provide that movement for them to prevent pressure ulcers. You might have to do movement to prevent joint issues from prolonged bed rest. And you'll learn about this in the classroom. Okay, their eyes blink, there's a blink response. Their pupils respond to light. The pupils can be normal or abnormal. So you can apply the light with your pen light and look for observations. You can apply it directly and observe, and then you can apply it again and observe whether there's what's called a consensual response, meaning that the opposing pupil does exactly what the directly stimulated pupil does. So they have that ability. In doing the test for PERLA, the one thing that they cannot do is accommodate. So just assume and document that the accommodation test was done and it was normal. Their nose, like I mentioned earlier, can have a nasogastric tube placed in it. In addition to that, nasal cannula, the two low prongs that sit in the nose, can be used, and the tubings are applied around the ears and secured under the chin. Get careful, because their skin is capable of developing a breakdown or an abrasion or a lesion just from pressure. Just like the skin on their backs, so can the skin around some equipment that remains in place over a long period of time. So always inspect the skin around the nose and, of course, the skin around the ears to be sure that there's no signs, early signs of skin problems back there. Their mouths are always open. That's why you cannot take an oral temperature on them. And I mentioned that before. The temperature that you will be given in report can be used as if you had remeasured the temperature and there was no change. Their necks, if you look carefully at their necks when you're with them, they do have tracheas. And you know now that to find the carotid pulses, you identify the trachea and then you place your fingers in the groove between the trachea and the sternocleidomastoid. So that would be placing your fingers deep in the neck, in the lower part of the neck, because you don't want to be around the carotid sinus. So the simulator has carotid pulses, and like everything, they can be normal or abnormal. All right, so getting to the thorax, two of our simulators have, right below their subclavian bone, they have a subclavian IV site. Most patients, that's called a central vein IV site. Most patients do not have a central vein IV site. They have what's called a peripheral, one of the other peripheral veins, but don't let that throw you off. The two Mediman simulators always have a central one. It's a right subclavian site. And it's dressed, but again, the skin around it as you do your inspections can be normal or can show signs of infection. Their thorax has the bony structures that we use to identify locations. There are clavicles, so you can find the mid-clavicular line. There's a sternum and a suprasternal notch. You can go right down the sternum, and you'll notice that you'll feel either an elevation or an indentation. That is where the manubrium joins the body of the sternum. We know that in patients that articulates with the second intercostal space or rib. So that's how the nurse is able to use that landmark, and it is called the angle of Lewis, where the manubrium joins the body of the sternum, and it's used to help us find the second intercostal space. So here's mine right here, and if I go to the side, I'm actually in a space that would be the second space. And close to the sternum, I count the ribs and the space, until I get to the fifth left intercostal space, mid-clavicular line. So that is where the nurse should begin the assessment of cardiac sounds. It's not that he doesn't have cardiac sounds everywhere, but if you're trying to identify, is the PMI normal? Is it in the normal location, which, as you know, is the fifth left intercostal space, mid-clavicular line. Now, going up above the clavicles, I want you to think about how the apex, or the pointed area of the lungs, expand all the way up when a patient inspires. So our simulated patients have breath sounds above the clavicles. Those are the apices of the lungs, and they have breath sounds everywhere. They do not have the characteristic differences that you've learned about in class, like bronchial, bronchovesicular, vesicular. So don't depend on them to help you learn that. But they do have sounds. You always, when you have two of anything on a physical exam, you compare for equality. Is the amount of air that you hear there similar, almost the same as the amount of air you hear above the clavicles there? Then you go down and listen to breath sounds in the midfields of the lungs, and you'll learn in the classroom the exact procedure for that. The bases of the lungs, both anteriorly and posteriorly, are very important to auscultate, because if there is what we call atelectasis, that's collapse of the distal alveoli, often it occurs in the most distal area of the lungs first, which would be the base of the lung. Posteriorly, breath sounds are audible as well, so be sure that you turn your patient to auscultate the posterior breath sounds. While you have the patient over on their side, it's a good time for you to inspect the spine, whether the skin is intact, and any other findings posteriorly that you may want to observe. Going to the abdomen, their abdomens may be flat or they can develop ascites or distension. The abdomen also has bowel activity sounds, and they are audible in all four quadrants. And again, it can be normal or abnormal. The femoral pulses. Now I'm going to do all the pulses. Let me do the pulses at the end. So let me keep going with the extremities. We'll go up and do the upper extremities. The upper extremities, as you know, you're going to, like something that you have two of, you're going to just first inspect to see if they're equal, if they look symmetrical, and whether the muscle development is normal, whether there's good normal development. Now, normally when you're doing musculoskeletal assessment, you would ask the patient to take your hand and to squeeze, right? Testing for strength. But remember, the simulators cannot move. So you may ask aloud, what's the strength in the upper extremities? And the same will be done when you're doing the lower extremities, but you're asking the patient to push against your hands, and then you ask them to pull back against your hands for extension and flexion. But since they can't move, you have to ask aloud, what is the patient's strength in his upper extremities? And then when you get down to the lower extremities, ask for that as well. All right. Lower extremities, same thing, basically that you would assess for symmetry, muscular development, and then, like we said, strength, whether they're able to push against your hands, and for the equality of that strength. Very, very important. All right, let's talk about pulses, the perfusion. One of the perfusion aspects that we would always look for is the peripheral pulse. We talked about the main apical pulse, but let's talk about the peripherals. I mentioned that there are carotids. Now remember, you wouldn't be doing them both at one time. You learned this in the classroom. However, the rest of the peripheral pulses, you can actually evaluate them simultaneously. Once you learn to find the radial pulse, and I'll show you on myself, the simulator is exactly the same. On the thumb side of his arm, let me turn my camera this way, right here, by the beginning of the radial bone, in that groove is where the radial pulse can be auscultated. Okay? You can compare it in volume, whether they're equal in volume. You can also identify the volume of the pulse, whether it's a +2 or something abnormal. Now the brachial pulse, now this is an important difference. So I'm going to have to move my camera down where I can show you. On the Mediman simulators, and that's the two that you'll most likely use, okay, the brachial pulse on all of us would be located in the medial aspect of the antecubital fossa, right? Well, I can feel mine very well at this point. However, the simulator's brachial pulse is not located there. It's because it's a joint for the mannequin to be able to move his forearm. So the company, instead of putting it there, moved it down right below. So you need to know that the brachial artery pulsation is located right below the antecubital fossa. You will not hear carotid cough sounds if you don't apply your stethoscope there. Now, I know you learned in the classroom that sometimes we have to do a palpatory blood pressure to be sure that we have an accurate value of the systolic pulse of that patient, systolic blood pressure, I should say. So you've learned to do what's called a palpatory blood pressure measurement, where you only get the systolic. The simulator is able to do that as well. The rest of his pulses, his femoral, his popliteals, the pedal pulses, both dorsalis pedis and posterior tibial, are palpable. No special thing about that, just like on real people. Now, the simulator patient cannot change temperature or skin color. So that eliminates the testing for capillary refill, right? Because that is a test we do where we apply pressure and we look at the color change and whether it returns within less than 3 seconds. So that's another one of the findings that you'll just have to ask by asking out loud, what is the capillary refill in the upper extremities? What is it when you get to the lower extremities? Okay, that's it. The only other thing I'm going to tell you, this semester for the first time, we're going to be using our newest simulator. And because we need to maintain social distance, physical distance, we're going to run 3 simulators simultaneously. So this simulator is a female, and she's made by a different company, like she's not the same brand that the others are. It's actually the same company, but a different model. And she only has findings, pulses on the right side of her body. You know, her left side does not have any pulsation. You can remember that females are usually right. LOL. Okay. All right. See you in the lab.